Chandrasekhar, for the format of this evening,
Yeah.
you will start off, you and Nirmal, and then
Yeah.
Dr. Suke will say a few words.
No,
He has a speech.
he will give
He has
his
a speech.
talk.
He has a
Professor.
speech. Yeah.
Yeah. And after that, David Garcia will give a speech. He would speak on late neuromuscular complications of COVID.
Right.
Uh,
And there is a third person also.
Professor Laszlo Vexei.
Yes.
But for 2 days, he has not replied to my mail.
Okay.
He joins.
Right.
So after that, then we go for a panel discussion.
For the panel, yeah.
Yeah.
Swati is joined. Swati, welcome.
Good evening, sir. Good evening, everybody.
Good evening. So that leaves only Dr. Shefali Gulati.
Yeah.
Good evening, sir.
Yes, everybody's around. Hi, Shefali.
Hello, sir.
Good evening. Good evening. Yeah, so the quorum is full.
No, the international faculty is...
Two are still yet to come. Yeah.
Yeah. Professor Takahashi, we still remember the excellent Kyoto conference.
Thank you very much.
Yeah,
Did you enjoy?
Yeah.
Did you enjoy the conference?
Yeah, very much, very much.
Thank you. So it's a pre-COVID, very nice conference.
Yeah, pre-COVID.
It's a really beautiful city as well.
Yeah.
Thank you.
Very historical city, heritage sites, and it was, after the conference, we had spent some few days in.
That's good.
Yeah, going around.
Yeah.
Did you visit Golden Temple?
Yes. Most of the
Did
sites
you like it?
I visited in Kyoto.
Good.
Yeah.
Good.
And then from Kyoto, we went to Tokyo. And,
Tokyo.
Yeah.
This time the Asian Oceanian muscle disease is in Nara, the next one. In Nara, in Japan.
In Nara.
The flower city, is it? The flower city, the next year, 2023.
Next year,
yeah.
2020. I didn't know that, but yeah, that should be very nice. It should be very nice conference.
Yeah.
Nara is also very historical, ancient city.
Chandrasekhar, everybody has joined now.
Yeah.
So we may start the program.
Just wait for maybe 1 or 2 minutes and then we can start. What is the correct, your first name, Professor Takahashi? Risuke. We pronounce
Ryosuke. And my surname is Takahashi. So
Okay.
please call me, formally, please call me Professor Takahashi, and just call me Ryosuke. Ryosuke is my first name.
Ruske.
Yusuke.
Ryosuke. Oh, yeah, very good, very good.
Yeah. Thank you. Thank you.
Thank you.
Professor David Garcia, good evening. Good afternoon.
Hi, good afternoon. Hello, everyone.
Thank you. Thank you for joining. I
Hi.
think now we can, Professor Laszlo has also joined. Good afternoon.
Yes,
Professor.
good afternoon. And may I say that my family name is Vexay.
Vexay, yes.
Laszlo is the first name.
First name.
We use the same probably as in Japan, first the family and after the surname.
Oh,
that's the Japan, the situation is maybe a little bit similar.
yeah, very similar.
Yeah.
Usually, my name is Takahashi Ryosuke. So,
Yeah.
like you,
Yeah.
So we can start now.
Yes, please.
Yeah. Dear friends, good evening. I am Dr. Chandrasekhar Meshram, co-opted trustee of World Federation of Neurology and chief coordinator of public education activities of Indian Academy of Neurology. I welcome you all on behalf of World Federation of Neurology and Indian Academy of Neurology for this fifth session on neuromuscular weakness in this series of World Brain Week. Indian Academy of Neurology has been quite active in carrying out public education programs. Just to mention a few, on 30th January, we did neglected tropical diseases, 9th February, International Epilepsy Day, 24th March, World TB Day, 26th March, Purple Day, 2nd April, World Autism Awareness Day, 11th April, World Parkinson's Day, 30th May, World Multiple Sclerosis Day, 5th June, World Environment Day. And this type of activity continue throughout the year. And during this World Brain Day, we decided to have a World Brain Week and celebrate it with at least 100 activities throughout the country. So I have a great pleasure in welcoming Yusuke Takahashi, who is Professor and Chair, Department of Neurology, Kyoto University, Japan. And he is currently Vice President of the Asian Oceanian Association of Neurology. And he was the President of the Japanese Society of Neurology from 2014 to 2018. And he organized the wonderful World Congress in Kyoto in 2017. Welcome, Professor Takahashi. I would also like to welcome Professor David Garcia Azarin, who is the chairman of International Committee of Spanish Neurological Society. And he has interest in neuroinfection diseases, tropical neurology, headache, and many specialties. And his current interest now is in COVID-19, and he has published a lot of papers and did research in COVID-19. And he has a lot of publications and book chapters. Welcome, Professor David. I have also a great pleasure in welcoming Professor Vexey Laszlo. He's from Hungary. He's a professor of neurology at the Neurosciences Center and Research Center. And it's a great pleasure to have you, Professor Laszlo Vecsey, for this meeting. I would also like to welcome Professor Nirmal Surya, who is President of Indian Academy of Neurology, very dynamic and enthusiastic president in the history of Indian Academy of Neurology. I also welcome moderator of today's session, Professor Satish Khadilkar, who is Dean of Bombay Hospital Institute of Medical Sciences, Mumbai. And we have the excellent panelist, Dr. Shefali Gulati, who is Chief of Child Neurology Division, Department of Pediatrics, All India Institute of Medical Sciences, New Delhi. Dr. Shruti Nair, who is Associate Professor, Department of Neurology, Sri Chitra Institute, Trivandrum. Dr. Sandeep Pal, Associate Professor of Neurology, Medical College, Calcutta, and Dr. Swati Shah, Neuromuscular Specialist, Neurology Clinic and EMG Center, Ahmedabad. So we are going to have a great session. And once again, I welcome you all, and I request Indian Academy of Neurology President, Dr. Nirmal Surya, to say a few words.
Namaskar, good evening, ladies and gentlemen. It's indeed a great pleasure. आप सब लोगों का स्वागत है. We have today the day 5th of the World Brain Day, and today we have lined up the session on neuromuscular weakness. Extremely difficult to do everyday program with involving the international panelists along with our a team of Indian young neurologists, but I must compliment Dr. Chandrasekhar Meshram to coordinate every day and to get the movement going on. My call to all my members of Indian Academy of Neurology to give 100 program in a week has been heard, and they have taken it very seriously. And I can believe, and I know, and Meshram will endorse that at least we are going to have more than 200, 250 program in this week. Various activities throughout the country has been organized by many young neurologists as well as senior people, including the institute like PGI, AIMS, Niemens, Sri Chitra, etc., etc. So I'm thankful to that. Today we have galaxy of international speakers. My colleague at AOAN, Professor Takahashi, and then we have Professor Lazio and David from Hungary as well as USA going to talk. Not to forget our own leader in neuromuscular disorder, Dr. Satish Khadilkar, along with Shefali, Shruti, Sandeep, and Swati are going to be here to tell you about the neuromuscular weakness, what should we do, and also how do we approach. So without taking much time, I must say that Indian Academy of Neurology has taken the public awareness program very seriously. We have been doing this program for last 3 or 4 years, including the National Day and the Brain Week, which we do it in November. But this World Brain Day is very, very special. And Dr. Meshram is a national coordinator who has been very actively involved. We will keep on doing the more activities. Those who have missed out the previous sessions, they can log on to the YouTube of Indian Academy of Neurology, where all the programs are available. And I once again welcome all the speakers on here and hand over back to the Meshram to start the proceeding. Namaskar.
Yeah. Thank you very much, Dr. Nirmal Surya. I would like to tell you that this program is live on Zoom. It is live on Facebook and it's live on YouTube. So you can watch wherever you are comfortable with. And now I request Professor Yusuke Takahashi to speak and give his talk.
Thank you very much.
Yeah.
Thank you very much, Professor Meshram. First of all, I'd like to thank Professor Chandrasekhar Meshram and the organizing committee for kindly providing me with an excellent opportunity to give a few words for this webinar. The theme of World Brain Day 2022 is Brain Health for All. It means a worldwide effort to promote brain health and reduce the global burden of neurological disorders. Over 50% of the global population cannot obtain essential health services, including basic neurological care, and this will only continue to increase year by year unless appropriate measures are taken. We should keep in mind that high-quality neurologic care is safe, accessible, and effective, with an emphasis on human rights. So more than 50 million people having epilepsy and about 47 million with dementia. Neurologic disorders are now the leading cause of disability-adjusted life years worldwide, and the second leading cause of death. The goal of World Brain Day or World Brain Week is to share information about brain health and encourage universal efforts that brings awareness to the prevalence of brain disorders and the brain's vital role in humanity. I hope today's webinar on neuromuscular weakness will be of significant help to understand the value of brain health and the importance of its promotion. Thank you very much.
Thank you very much, Professor Yusuke. Now I request Professor Laszlo Vexey to address the session.
Thank you very much. First of all, I want to thank to Professor Chandrasekhar Meshram for this really very kind invitation. On behalf of the World Federation of Neurology Standards and Evaluation Committee, I would like to say some words to you. You see, as a couple of days ago, our president, Wolfgang Griesold, mentioned that brain disorders are the leading cause of disability and the second leading cause of death. We need to highlight the need for quality of brain health globally by supporting the implementation of brain health in national health policies and ensuring access to the appropriate and timely diagnosis, treatment, and care for everyone. All we know that during the World Brain Day, we have excellent opening speakers, Wolfgang Griesold, David Dogig, Tissa Vieratna, and not to forget about Count Dua, who is the unit head of the Brain Health Unit at the World Health Organization. So the World Health Organization also paid a quite high attention to our activities. Concerning Europe, you see, I am from Hungary. It's a small country with 10 million people in the very center of Europe. I want to say some words about the activities of the European Academy of Neurology concerning the brain health strategy. I had the privilege to be the vice president a couple of years ago, the European Federation of Neurological Societies, so I have quite close contact with this organization. You see, this year also marks the launch of the European Academy of Neurology's Brain Health Strategy. The IAN strategy aims to develop a holistic approach to brain health, which benefits society not just through a decreased healthcare burden due to neurological disorders, but through improved quality of life and productivity throughout an individual life course. The ENS vision is of a future in which individuals, populations, clinicians, and policymakers understand the benefits of good brain health and have the information and opportunities to preserve the recovery of brain health. Also, as I mentioned to you that we are very active in the World Federation of Neurology Standards and Evaluation Committee, and I just want to say some words about our view. We think that science, research, probably the most important part, because education is based on scientifically qualified and productive people. So that's a very important point. And also patient care is very strongly related to science, since today we are moving to the personalized medicine, genetics, biomarkers, cell biology are more and more important in the everyday practice. So therefore we focus on science when we speak about education. I just mentioned to you, maybe some of you will be interested in the activity of this committee. The task of the WFN Standards and Evaluation Committee is to evaluate applications of international or national neurological congresses and any other scientific meetings in neurosciences of the WFN that apply according to its guidelines as noted on the application form, which can be reached on the WFN website. The purpose of this WFN activity is to keep and improve the standards of the neurological scientific meetings that apply for WFN, endorsement through accreditation according to the structural guidelines, information on the required ethical issues, and limitation with the pharmaceutical and other industries are to be found in the application form. Once a completed application is received, applications are notified of the decision within 2 weeks of their application. If the application is approved and the meeting is endorsed, it qualifies to use the WFN logo. It is announced on the WFN website and WFN newsletters, and after the meeting, a brief summary will also be published on the website. So if you have good meeting with good speakers, I strongly suggest you to apply because WFN has acquired high prestige, maybe the highest prestige. And very finally, I would like to some words about our Danube activities. This Danube neuroscience activities is focused around 100 million people in the Central European region. Maybe many of you remember Franz Gerstenbrand. Unfortunately, he died around 10 years ago. I think the next year he would be 100 years old. He was a very good friend of mine, and he was a very important activity in this Danube neurology. Sometimes he told me that the European Federation of Neurological Society was burned in the Danube symposium. The present activity is Danube symposium is on MS, multiple sclerosis. The first step, we wanted to see what's going on with the requirements of the MS centers, which was established by European Academy of Neurology. We finished it and we just sent it for publication. The second one is what about the MRI requirements, whether the different centers concerning atrophy and others, how do they fulfill these requirements? Do they have the sufficient knowledge? And the third one is on CSF and biomarkers. That will be the third step. And of course, we will move also to neuromuscular disorders, and we plan to move to some other disorders, but of course, it takes time. So in conclusion, I strongly suggest you to apply for this committee endorsement, and it is my real pleasure that I had the chance to participate of this important meeting. Thank you very much.
Thank you, Professor Laszlo Vexey. And I must mention that Professor Vexey is international delegate from Hungary for many years for Council of Delegate meeting. And I have been the national representative for India for 6-7 meetings. And we sit side by side for Council of Delegate meetings. So it's a great pleasure to have you here. And when we conducted the neuroinfection series, Professor Vexey has very kind enough to grant the permission of from World Federation of Neurology, from Standard and Evaluation Committee to go ahead with the neuroinfection series, which was a very successful and wonderful series. Thank you very much, Professor Vexey, for being with us. Now I would like to request Professor David Garcia Azarin, and he has a lot of work on COVID-19, and during this sessions, we did not talk much about COVID-19. So I would, on popular demand, I would like to request Professor David to say something about long-term complications of COVID-19. The people would be very happy to know. Professor David Garcia Azarin.
Thank you, Chandrasekhar. I am pleased to be here with you today And as you pointed out, I will speak more about COVID-19 and instead of neuromuscular symptoms, albeit both of them are highly relevant. I will share with you a bit of our experience with post-COVID complications, and we have been working mainly on headache. We are now focusing more on cognitive symptoms and also neuromuscular manifestations, but the work that we have done in the headache field is more advanced. So I would like to share my screen if possible, and I will present briefly about the most recent updates that we had in these regards. So these are my conflicts of interest. The first question that we should focus on is it worthwhile to speak about neurological manifestations of post-COVID? And it seems that yes, because cognitive symptoms, neuromuscular manifestations, and also headache are within the most prevalent post-COVID manifestations. So in the case of headache, we started analyzing this topic 1 year ago, and by that time, we already saw that the prevalence of headache after COVID was relatively high, and approximately between 10 and 20% of the survivors still complain about headache. So this was the first remarkable issue that we observed. This applies also for other manifestations like cognitive symptoms and some neuromuscular complaints, but apparently it seems that the prevalence decreases over time. And this is what we wanted to assess in this study that we did in Spain, collaborating with 5 other sites. We collected a sample of 905 COVID survivors that presented headache during the acute phase, and we observed that the median duration of the headache was 14 days. But the problem was that after 2 months, if the patient was still suffering from headache, it seemed to be quite unlikely that the headache resolved spontaneously. So this suggested that we need to pay attention on this, and in case the patient persists suffering from headache, we may do something, and we will explore later what can we do regarding treatment. About the possible predictors of a more prolonged duration, we analyzed a series of variables, and one of the theories that we have is that COVID-19 may trigger a predisposing headache biology, and some people may get a worsening of the pre-existing primary headache disorder, but some other patients may develop or may express a headache that had never previously occurred. And this is associated with the phenotype of the COVID headache. Something very relevant is the effect of the variants, and even more the effect of vaccination, because the epidemiology of the neurological manifestations and also the duration of some symptoms may have changed. So what we did was to compare the duration of the headache and the clinical phenotype between patients that had been vaccinated versus patients without any prior vaccination. And we observed that the vaccination shortened the duration of the headache by 10 days, meaning that in people who got vaccinated, the median duration is around 4 days, while in the patients that, as we saw before, in the non-vaccinated patients, the median duration was 14 days. So this is a positive argument to support the vaccination campaigns. And in the event that the patient persists suffering from the headache, we may remember that the clinical phenotype of the headache is typically like a bilateral headache with frontal predominance, pressing quality, and the moderate intensity, in which the typical migraine-like features are relatively common, like worsening by physical activity, photo and phonophobia, and so on. And this is the reason why the most promising treatment was amitriptyline, because as you know, amitriptyline is a cheap drug, old but a very positive one, which is the first-line treatment of tension-type headache and one of the first-line therapies for migraine. So we tried to evaluate what happened, what occurred with these patients when we treated them with amitriptyline. And we observed that there was a statistically significant reduction in the number of headache days per month after receiving amitriptyline, and approximately half of the patients presented some degree of response, and 44% of patients responded to the treatment. So this is something also promising. And we observed that there were some predictors of the response to amitriptyline, which included the prior history of tension type headache, and also the presence of other comorbidities like anxiety, depression, insomnia, and all of this. Now we have moved to a larger study where we started analyzing also the effect of other therapies like anesthetic blockades, botulinum toxin, beta blockers, which are within the drugs that have been more frequently used. And as you can see, amitriptyline is still probably the drug with the best results, but in some selected patients, you may consider some alternative therapies. And interestingly, we said that this persistence of the COVID-related headache may be explained by a predisposing biology. So what we wanted to do in our most recent study was to compare the brain of people who suffer from persistent post-COVID headache and healthy controls. And it seems that there are some differences both in the gray matter and also the white matter of the patients, mainly in areas which are associated with the olfactory cortex. And in terms of white matter, there are large connectivity differences between patients and controls. So to conclude, we have learned that if the headache persists after 2 months, it will likely become chronic, unless the patient is vaccinated, where the prognosis seems to be much better. So we should still recommend patients to be vaccinated. By now, in most sites, we still treat patients according to the phenotype of the headache, which seems a reasonable approach. And the amitriptyline, which is, as I mentioned before, within the first-line drugs for both tension type headache and migraine, is the drug with the best results so far. So thank you very much. And I am, as I said, I'm pleased to be here with you today. Thank you.
Well, thank you, Professor David Garcia Azarin. And he was, traveling, going around, and then we had to. He was very kind enough to be here for this session. Thank you very much, Professor Wolfgang Griswold, WFN president, has also joined for this session, and he heard talk by Professor Laszlo, and part of your talk also he had just mentioned. Professor Griswold, are you still there? No, I don't see him now. I think he had another commitment. So thank you very much. And now I hand over the mic to Dr. Satish Kadil.
Chandrasekhar, Dr. Griswold seems to be there.
Yeah. Yes, Professor Griswold.
Thank you, and I'm sorry that I'm short with time today. I just did not know it, but I think if I hear neuromuscular weakness, I'm always excited. I mean,
thank you. Please say something about it.
I just wanted to say that I think David is involved in that group too, that we are trying to find out about neuromuscular weakness, neuromuscular symptoms following COVID and following vaccination. There's a small group working on this, and I think we will hopefully produce some results. There was a meeting in Europe in the beginning of July from the International Congress of Neuromuscular Disease, and there were, I think, two main points I just want to mention here of its weakness. One is this study from the English, from Dr. Lunn, who evaluated the occurrence of Guillain-Barré syndrome in UK, and came to the conclusion that it was not, the number was not increased. That's one important point. And the other important point was that from Dr. Amato, who systematically analyzed muscle weakness, myasthenia, neuropathies, small fiber disease, and he came to the conclusion that for most conditions, it is not quite clear due to the many individual cases if it's really increased and how much the increase is. The only thing that seems to be quite clear, and I don't have the figures now with me, is that obviously after vaccination, depending on the vaccine, there seems to be an increase of, let's say, for some vaccines, facial palsy or Bell's palsy, for some plexopathies, for some GBS. But what I learned from two speakers, one was Dr. Pushpa from Boston and the other one was Amato, that is within the range what you would expect after vaccination, because there's always some kind of autoimmune peripheral nerve lesions with that. So this would be my short statement in regard to COVID and neuromuscular in regard to that. But it's as I said, and I suggested or as I'm suggesting to Chandrasekhar, that we put the names and the topics on our World Federation website, because there were really good lectures and it may be good for people to see that. Thank you.
Thank you.
Sorry
for
my haste. Thank you.
Thank you. Thank you very much for being with us. I think it was a great moment that you could join this session. Thank you.
Thank you.
Over to you, Satish Khadilkar.
Yeah. Good evening, everyone. And we're already half an hour into the program. So let's start off with the panel discussion. And the main theme today, as you know, is nerve and muscle diseases. And we have 4 panelists with us. We have Dr. Shefali Gulati from New Delhi. We have Dr. Sandeep Pal from Kolkata, Dr. Sruthi Nair from Trivandrum, who is at the moment in England. And 4th panelist is Dr. Swati Shah from Ahmedabad. So we will try and cover some of the aspects that I think people should know about nerve and muscle diseases. And let me begin by making you aware of the magnitude of the problem. You know, amongst neurological disorders, you heard this evening that neurological disorders are leading cause of disability and also contribute to death. And as communities go on changing from infections to immunological to neoplastic, I think, and as longevity goes on increasing, neurological diseases become more and more common. Almost 10% of neurological diseases are nerve and muscle diseases. And the nerve and muscle disease means diseases of the nerves, diseases of the junction of the nerve and muscle, like myasthenia gravis, diseases of the muscles, and some other related situations. So one by one, let's initially take information from our panelists. So maybe we can start with Dr. Swati Shah. Dr. Swati, can you tell us a little about which are the common diseases of the peripheral nerve? And after you tell that, could you also tell people as to how should they recognize a nerve disease? So I think 2 parts of the thing. Which are the common diseases that you see in peripheral nerve in general, and how should people recognize them? What are the symptoms? Swati.
Sure. Thank you, sir. See, for any kind of disorder, if we're dealing with the nerves, so we call it peripheral neuropathy just because it affects the peripheral portion of the nervous system. So anything that deals with the brain and the spinal cord is the central, and anything that is affecting the nerves of the arms or the legs is considered a peripheral system. And so any disorder or dysfunction or the damage to the nerves of the arms or the legs is considered a neuropathy. So that is the general term that we use for the disorders of the nerve. And if you broadly classify these disorders, there could be disorders that you have inherited. So those could be inherited neuropathies that result from an alteration in the DNA. So DNA is the genetic code that you inherit from your parents. and these account for the proteins that are part of the nerves. So if there is a dysfunction of these DNA, the genes, then you can also have neuropathies. So those are considered inherited group of neuropathies. You could also get neuropathies because of certain processes that happen in your body. So those will be more like acquired neuropathies that you develop because of some disease process or some exposure that happens to your body. So those will be broadly considered as acquired. Among the acquired, the most common reason people would come to us with the neuropathy would be the diabetes. This is the most common, the leading cause of neuropathy in worldwide, I would say, not just in India. So 60 to 70% of the people who have diabetes would have some symptoms of or signs related to the neuropathy in their body. The neuropathies acquired can also happen because of the immune dysfunction in your body. The immune dysfunction could just affect the nerves, so it can be restricted to the nerves. So you could have inherited, so you could have autoimmune neuropathies that could happen just suddenly after exposure to virus. So we have talked about GBS happening after the COVID-19. So that is a more of an acute onset immune mediated neuropathy after exposure to a virus or a vaccine that has happened. Or sometimes they could happen on because of the immune dysfunction originating in your body. So those are immune mediated. We always look for these neuropathies because these are very treatable and we get good response with immunotherapies for these kind of neuropathies. Neuropathies can also happen because of the endocrine dysfunction. As I said, diabetes is the most common, but the other endocrine disorders like thyroid, adrenal dysfunction can also cause neuropathy. Neuropathy can happen because of exposure to drugs, and especially in our country where TB still continues to be prevalent. The drugs that we use commonly to treat tuberculosis can sometimes cause neuropathy, especially. So it can happen because of the exposure to drugs. Other big class of drugs that can cause neuropathy are the chemotherapeutic agents, the drug that we use to treat cancer. Sometimes that can commonly cause neuropathy. So we always look for these kind of exposures that patients may have. Sometimes it may not be the drugs, it could be the heavy metals, which knowingly or unknowingly patients may be taking. Sometimes it may be a concoction with Ayurvedic medicine or something else that might lead to increased exposure to these heavy metals. It could be a toxin exposure. So it could be related to a work-related exposure to a chemical or that can lead to a neuropathy. Sometimes it could be a deficiency of a simple vitamin C. We all know vegetarians are very prone to vitamin B12 deficiency. So it could be a simple vitamin deficiency that can lead to neuropathy. Or it could be other vitamins, especially in patients with chronic alcohol use. Their diet could be poor in other nutritive substances that can lead to deficiency of thiamine or other vitamins, which can also cause neuropathy. So there could be many reasons that people can present with neuropathy. The most common symptoms that patients feel about neuropathy, so if they have any unusual tingling, pain, burning, stinging sensation in their hands or feet, or if they have weakness in their hands or feet, that could be the signs of early neuropathy, and then that should alert them that there is something probably wrong going on with my nerves, and I should consult at least my primary care physician or a neurologist and talk with them about these symptoms.
Right. Thank you. Thank you very much. I think just to translate a little bit of what you said in Hindi, डॉक्टर स्वाति ने ये कहा कि अगर हाथों पैरों में झंझनाटी हो या कोई ताकत में कमी हो तो न्यूरोपैथी हो सकती है। और उन्होंने बताया कि न्यूरोपैथी की इतनी अलग अलग वजह होती है कि डॉक्टर के पास जाना जरूरी है, क्योंकि इसमें से काफी सारी ट्रीटेबल है। तो हाथों पैरों में झंझनाटी और वीकनेस, फिंगर्स यूज नहीं करना, टोज में चप्पल नहीं पकड़ना, ये टाइप के सिम्टम्स आते हैं, तो यू शुड अप्रोच the family doctor or an MD doctor or a neurologist, whoever is accessible to you. Thank you very much, Swati. Let's ask Dr. Shefali Gulati now. As you know, Dr. Shefali Gulati is a pediatric neurologist, and there are so few of them. So, Dr. Gulati, can you please tell us a little about which neuromuscular diseases you see in children? बच्चों में कौन सी नर्व और मसल की बीमारियां आपको दिखती है?
बच्चों में जो सारी जो मोटर यूनिट की प्रॉब्लम्स हैं सारे ही देखने को मिलते हैं, जैसे बताया गया था मोटर यूनिट में जो कि हमारे जो स्पाइनल कॉर्ड में एंटीरियर हॉर्न सेल है और जो नसें वहां से जाके मसल्स में जा रही हैं, फिर जो मसल्स और नसों का जंक्शन है न्यूरो मसल जंक्शन, और वापस वहां से मसल से आपको जो स्पाइनल कॉर्ड में जा रहा है, एंड ऊपर से देयर इज अ कंट्रोल फ्रॉम द ब्रेन, तो वहां से भी कंट्रोल होता है। तो हर चीज में कोई ना कोई प्रॉब्लम होने से प्रॉब्लम्स होती हैं, और जो पीडियाट्रिक्स में देखी जाती हैं, जो मोस्ट कॉमनली देखी जाती हैं, वो है हमारी एंटीरियर हॉर्न सेल से रिलेटेड प्रॉब्लम है, जिसको SMA कहते हैं, स्पाइनल मस्कुलर एट्रोफी। उसके अंदर वो एंटीरियर हॉर्न सेल की प्रॉब्लम होती है, बच्चा फ्लॉपी होता है, फ्लासिड होता है, बिल्कुल ढीला होता है, बिल्कुल हाथ से फिसलने टाइप का उसका जब उठाते हैं तो है, लेकिन वो उसकी भी डिफरेंट सिवियरिटीज ग्रेड्स होते हैं। SMA टाइप 0 से लेकर उसका टाइप 4, जो 0 वाला है वो बिल्कुल नवजात शिशु में होता है, वो पहले ही जब बच्चा पेट में होता है तब से मैनिफेस्टेड होता है। SMA टाइप 1 फर्स्ट फ्यू मंथ्स में होता है, और SMA टाइप 4 जाके एडल्टहुड में होता है। तो काफी डिफरेंट स्पेक्ट्रम है, लेकिन जो SMA टाइप 1 वाले होते हैं बच्चे जो फर्स्ट ईयर ऑफ लाइफ में जो होते हैं, जिनको प्रॉब्लम होती है, उनको बार बार उनको सांस लेने में प्रॉब्लम होती है बिकॉज ऑफ द वीकनेस, एंड जनरली वो दे सकम, उनकी हम उनको खो देते हैं। लेकिन जो टाइप 2 वाले जो 1.5 साल की उम्र के आसपास उनका से पहले उनका एनवेसेशन होता है, और टाइप 3 वाले जो 1.5 साल के बाद होता है, वो बाद में चल के वीकनेस रहती है उनकी, और जो उनकी वीकनेस ज्यादा होती है प्रॉक्सिमल होती है। मतलब जब हम चल रहे हैं तो हमारे को जो उठने बैठने के अंदर प्रॉब्लम है वो ज्यादा है उसके अंदर। और ये बच्चे जो हैं, कुछ हैं बच्चे जो बैठ नहीं पाएंगे, कुछ हैं जो बैठेंगे, कुछ चल पाएंगे, डिपेंडिंग ऑन टाइप 2, 3, 4। तो ये SMA का एक देखा जाता है। और दूसरा दूसरा कॉमन प्रॉब्लम है वो डूशेन मसल डिस्ट्रोफी देखा जाता है। डूशेन मसल डिस्ट्रोफी उसके अंदर जो है हमें बच्चे दिखते हैं जो जनरली 3-4 साल तक ठीक होते हैं, फिर वो कोई उबड़ खाबड़ चढ़ा कर चल रहे हैं या टर्न कर रहे हैं, जब कॉर्नर टर्न कर रहे हैं कोई साइड में तो वो गिर जाते हैं। फिर हम देखते हैं कि उनके काफ्स जो होते हैं, जो उनके टांगों में जो उनके कूल्हे होते हैं, वो उसमें काफ्स में सूजन होती है, वो स्वेलिंग हो जाती है जो उनके टांग में लोअर उसमें। और उनको जब नीचे से जमीन से बैठे होते हैं, कई बार हमारे देश में जब हमारे सारे जो वॉशरूम्स वगैरह जनरली इंग्लिश स्टाइल के नहीं होते, जो नीचे से बैठ के उठ रहे हैं, तो उसमें प्रॉब्लम होती है। तो ये सारी चीजें दिखती हैं। और बाद में जो उसमें भी जो डूशेन मसल डिस्ट्रोफी है वो बेसिकली एक डिस्ट्रोफिनोपैथी स्पेक्ट्रम में आता है, जिसमें 8-9 प्रकार की होती है। डूशेन मसल डिस्ट्रोफी सबसे सिवियर है, जिसमें अल्टीमेटली 10-12 साल में बच्चे व्हीलचेयर बाउंड हो जाते हैं। बैकर्स हैं जो एडल्टहुड में चले जाते हैं, और बीच में काफी और स्पेक्ट्रम है। कई बार मोस्टली जो डूशेन मसल डिस्ट्रोफी है जो है, ये जो डिस्ट्रोफिनोपैथीज है वो एक्स लिंक्ड होते हैं। वो उनमें लड़कों में ज्यादा होती है, क्योंकि जो उसकी जो जेनेटिक्स जिसके बारे में बाद में बात होगी तो उसके में समझ में ज्यादा आएगा, तो उसमें लड़कों में ज्यादा होती है, पर कुछ फीमेल्स में भी उसकी मैनिफेस्टेशन होती है। तो ये दो बहुत कॉमन है। ऑल्दो हमारे पास कुछ और जो न्यूरोमसल जंक्शन की प्रॉब्लम्स होते हैं, मायोसिनिया ग्रेविस जो एडल्ट्स में और छोटे बच्चों में ज्यादा होते हैं, उसमें बेसिकली जो वीकनेस होती है, आंखों की जो पलक है झुक जाती है, और क्या होता है सुबह बच्चा उठा है तो पलक खुली हुई है, लेकिन ओवर अ पीरियड ऑफ टाइम पूरा दिन में फैटिगेबिलिटी होती है, वो पलक झुक जाती है। कई बार स्वॉलोइंग डिफिकल्टीज होती है, खाने की प्रॉब्लम, चूइंग की प्रॉब्लम होती है, एक वो वाली भी होती है। और एक स्पेसिफिकली जो बच्चों छोटों में आएगी जो कंजेनिटल माइस्थेनिया ग्रेविस माइस्थेनिक सिंड्रोम्स होते हैं, उसमें भी ये जो प्रॉब्लम होती है, उसके अंदर उनको सांस वगैरह की प्रॉब्लम भी साथ में होती है, और फैटिगेबल वीकनेस होती है। और मांसपेशी की डिस्ट्रोफीज के अलावा मायोपैथीज भी प्रॉब्लम होती है, जिसमें बच्चों को हाथ पैर में वीकनेस होती है, और सांस में प्रॉब्लम, और भी बाकी सिस्टम्स में प्रॉब्लम हो सकती है। तो मतलब और न्यूरोपैथीज भी होती हैं जो हेरिडिटरी वाली होती हैं, वो भी हमें बच्चों में दिखती हैं, जैसे आपको अभी बताया। साथ में बच्चों में LGB का भी बताया, साथ में CIDP भी होता है, जो बार बार वो ऑटोइम्यून से होता है, वो रिपीटेडली होता है। तो सारी, और साथ में हमने लेड टॉक्सिसिटी के बहुत देखे हैं। अभी वो रिसाइकलिंग ऑफ लेड बैटरीज अभी भी होती है हमारे देश में, तो वहां से पेरेंट्स आते हैं, वो अपने उनके कपड़ों से उनके घर में आते हैं, तो उसे लेड का एक्सपोजर से भी, ऑल्दो हमारे पेट्रोल में तो लेड हट गया है, लेकिन जहाँ इलीगली रिसाइकलिंग हो रही है उसके थ्रू भी होता है। तो बेसिकली सारे स्पेक्ट्रम को हम बच्चों में देख सकते हैं।
Thank you. Thank you very much. Maybe at this point, we can ask our international faculty members for their opinion. What has been said about peripheral nerve and children's neuromuscular disease up till now is that diabetic neuropathy and deficiency neuropathies are very common in our situation. And spinomuscular atrophy and Duchenne muscular dystrophy are the common problems in pediatric neuromuscular. So maybe we can ask Dr. Laszlo and Dr. Takahashi and Professor Griswold, if he's there, and Dr. David, what are their comments on this? What do they see in the populations where they work? Dr. Takahashi, you want to make a comment? You're on mute, I think.
Sorry for your muting. Thank you for your question. In Japan, we regarding peripheral neuropathy, we see many immune-mediated neuropathies, including CIDP, Guillain-Barré syndromes. So probably we don't, and also we see diabetic neuropathy, many patients. So, but we don't see many patients with vitamin deficiency neuropathies, which was caused by vitamin deficiencies. So most of the research are focusing on the immune-mediated neuropathies. CIDP is one of the most hot topic in research, because we don't actually we don't know the real cause of CIDPs. Yeah. Only a few portion of CIDP is elucidated in a sense in terms of its cause. So
right,
that's in Japanese situation. And in muscular diseases, the hot topic in Japan is now in muscular dystrophies, Duchenne muscular dystrophy, because new therapies using antisense oligonucleotide is developing. And some of the antisense nucleotide therapy is approved by the government. So we look forward to the outcome of these therapies.
Right. Thank you. Thank you very much. Dr. David, you would like to make a comment?
Sure. I think that here in this part of Europe, the first cause of neuropathy is diabetes, and the second cause of neuropathy is also diabetes or pre-diabetes, because of the food habits that the population is acquiring. So something that it's relevant is that when you have to treat a patient, it is very important to rule out all the potential causes that are treatable. So the nutrition deficiencies are within the list of treatable causes, and we should always keep them in mind. And also something relevant that may change in the future is there are new drugs for the treatment of obesity, in particular obesity in patients with diabetes. And I think that this may have an important influence on the risk of neuropathy because of the better control of the metabolic situation. So let's see what happens in 5 to 10 years.
Lovely. Thank you. Any other comments? Dr. Meshram, you want to say something?
No, I think Professor Pekse would like to say something about it.
Is he there?
Yeah, he's there.
Oh, yeah, please. Yeah.
Thank you very much. I think the situation is very similar in my country to Spain. So diabetes, that is the biggest problem. I think it's very hard to tell you that, but we have around maybe 10% of the population at some level diabetes. The other problem, what probably my colleague didn't mention from Spain, is alcohol. So alcohol-induced neuropathy, another very important point. So to tell you the truth, if we think about the public health view, these neuropathies can be avoided if the diabetes would be treated in the right way and not to use alcohol consumption. So that is a public health problem. Of course, CIDP and all of these things happen as generally it happens all around the world. But concerning the public health, these two are the most important part. Thank you very much.
Yeah. I think it's very interesting that you bring out the alcohol as one of the causes. It is very common in India as well, and particularly with the locally made alcohol preparations and the adulterations with the methanol. Sometimes they are very, very severe. So yes, that is a major health issue. even in India, particularly the rural part of the country. Yeah, thank you. So let's go to Dr. Pal and ask him, Dr. Pal, can you tell us a little about the neuromuscular junction disease, and how should people, what should people be on the lookout for?
As we all know, neuromuscular junction is a area which transmit the impulse from the nerve ending to the muscle membrane, so that the neurological control is being transmitted to the muscle and the ultimate effector function. So there are different types of neuromuscular junctions. Broadly, we can classify into acquired disease and a congenital or inherited disorders. Inherited disorders, by and large, is not that common, which is called a congenital myasthenic syndrome. But the most common thing is acquired and immune mediated. The most common thing what we encounter is acetylcholine receptor antibody positive myasthenia gravis. However, there are different types of autoantibodies that have been discovered over the years. The main presenting symptoms of neuromuscular junctions are specific parts of the muscles that are being involved. As for examples, muscles involving the ocular movements, the muscles that will move the eyes in different direction, the eyelids, facial muscles, the muscles that is related to chewing and swallowing. And on the top of this, they might be associated with a proximal weakness of both an upper limb and lower limb. In case of proximal upper limb weakness, they will have a problem on combing hairs, putting something over head. And in case of lower limbs, there is difficulty in getting off, a history suggestive of knee buckling and fall. But the most important diagnostic features is cranial musculature involvement. And initially it has been highlighted by the earlier speaker that diurnal variation, usually they are better in the early morning, and as the time passes, they will deteriorate. And the fatigability, these are the cardinal manifestation of neuromuscular junction disorders. And by this main clinical manifestation, we need to differentiate from other seemingly similar disorders from other neuromuscular disorders. Thank you, sir.
Right, right. तो डॉक्टर पाल ने जैसे बताया कि माइस्थीनिया ग्राविस और माइस्थीनिया के जैसी जो बीमारियां हैं वो बहुत कॉमन तो नहीं है, लेकिन बहुत ट्रीटेबल है। तो हर एक को उसके सिम्टम्स के बारे में थोड़ी जानकारी होनी चाहिए। Dr. Pal, would you like to elaborate a little bit on the fatigue aspect? I mean, fatigue is such a common symptom. When do you really suspect myasthenia? And when fatigue is due to so many other things, starting from anemia to system disease and what have you?
The word fatigue is very ambiguous from neurological point of view. In almost all neuromuscular junction disorders will have some amount of fatigability if there is a profound or at least moderate weakness. What I understand by the word fatigability in myasthenia gravis is the very minimal or no weakness in the static position, which significantly increases, not just increases, which significantly increases when that muscles is more and more being activated. Say, for example, I am going upstairs, on 3 or 4 stairs, there is no problem. But from 5 onwards, I will have some problem. During combing, I can do 2 or 3. After that, there is a significant problem and my hand is being tired. Same thing happens in case of eyelid. Initially, after getting up from sleep, there is normal eye opening, but as the day passes, there is, as it is constantly being elevated, so eyelid will go down. Same thing happens in mastication. If you go on taking roti 1, 2, this is fine, but say after 2, there is difficulty and there is tiredness in the jaw muscles. So you need to take a rest before going into the third one.
Right. That is very helpful. Now let's go to the next topic, the muscle disease, and we'll request Dr. Shruti Nair to tell us about which are the common muscle diseases that she sees and the symptoms that they should be aware of. When
Thank you,
should they
sir.
suspect muscle disease? Yeah.
So there are the same way that other speakers have been mentioning, the problems with the muscle can be those which you acquire, that is non-genetic causes. And there are causes which come because of problems in the genes which code for the muscles. So let us look at the acquired causes, which are very important because most of them are completely treated. And the very important cause of that is a drug-induced cause. So there are medicines which can actually lead on to weakness of muscles. And among them, I would say the most important is the medicine which we use to decrease the cholesterol. So statins, you may have heard of atorvastatin, rosuvastatin, and those medicines are very commonly used to reduce your cholesterol levels. And although it's a very rare complication, they can sometimes lead to a severe muscle disease associated with some weakness of muscles. More commonly, they produce pain in the muscles. So up to about 10% or more of people who are taking these medicines may have just muscle pain and fatigue, which is obviously different from what Dr. Pal was telling. There is no weakness of that, but only the patient feels difficulty in continuing their job without any overt weakness. So very rarely they can have a very severe muscle weakness as well. There are other medicines which are less commonly used, like chloroquine, which is a medicine which is used in malaria. There are medicines which are used for cancer therapy. There are medicines which are used for treatment of HIV. All these can also lead to muscle weakness, but these are very uncommonly used. Another very important cause is an immune problem, which is known as inflammatory myositis or inflammatory myopathy. Now here, there are certain abnormal proteins or antibodies which are produced, which actually fight against your muscle and then causes muscle weakness. And this is also very important to know because these should be treated with specific therapies which suppress this abnormal immunity, and only then will there be an improvement of the outcome. And these conditions are usually associated with or may be associated with problems in your skin or other diseases which affect immune system, like joint arthritis or ulcers in the mouth and other conditions which can also be caused by immune problems. Now, there are another set of problems which are infectious muscle diseases. So anytime you have a viral disease, there may be many people who have experienced muscle pain. And this is a form of viral myositis. This is usually very mild and the only symptom is usually muscle pain. Rarely you can have a weakness associated with this, especially in children. Certain diseases like leptospirosis, which is caused, Wheels disease also it's called commonly. It can cause very severe muscle weakness. There are some tick-associated infections which can cause severe muscle weakness. Other conditions are your problems with thyroid problem, severe hypothyroidism, that is poor action of thyroid or increased action of thyroid can cause muscle weakness. You have another hormone called parathormone or parathyroid hormone, which will regulate the calcium, etc. in your blood. And if that is abnormal, that can also cause muscle weakness. And if you have problems in certain electrolytes in your body, you know that there are electrolytes like sodium, potassium, etc. And if potassium goes down very much for whatever be the reason, either because of some other systemic disease that you have, a kidney problem, diabetes, etc., or because you've had a lot of vomiting or anything, that can also, or certain medicines also, that can also cause muscle weakness. So any change in electrolytes can also cause muscle weakness, and all these are easily correctable. And then we have a very large group and a very important group of muscle diseases, which is genetic causes. So this occurs because there is a problem in genes which code for certain proteins of muscles. So each protein in our muscle requires some gene to be responsible for it. So if you have a problem in any of those genes, it can result in an abnormal function of that protein and will result in muscle diseases, of which the most common is muscular dystrophy. I'm sure we'll deal with this in detail later. So I'll stop it here. Now, how do we recognize a muscle disease? The single most important presentation is just weakness of muscles without any sensory problems. The way we heard with nerves, there will not be any sensory problems at all. The patient will have mostly weakness. And the most common pattern which you see is that it will be equal on both sides. Both legs and both arms will be affected. And it is usually the upper part of the arms and the upper part of the legs which will be more affected compared to the feet and the hands. This is the most common pattern of muscle weakness. So along with that, you can also have muscle pain and even cramps of muscle. And importantly, one symptom which is very, very specific for muscle is what is known as myoglobin urine. And what that is you have a reddish discoloration of urine, which usually comes after a heavy exertion. And this is because your muscle breaks down and the product is excreted in the urine. This occurs specifically when there is a lack of energy in the muscle, or when the muscle is suddenly undergoing a severe damage. And this is a very specific presentation of muscle disease. So in short, if you have muscle weakness, muscle pain, cramps of muscle, and very rarely this reddish discoloration of urine, these can all be symptoms of muscle disease. You can also have weakness of muscles of the eye and throat and tongue, etc., but that is very uncommon, or these are very specific for certain muscle diseases. Thank you.
Thank you, Dr. Sruti. हिंदी में ट्रांसलेट करता हूँ. इन्होंने बताया कि अगर आपको चेयर में से उठने में दिक्कत है, जमीन से उठने में दिक्कत है, शोल्डर्स को ऊपर लेने में दिक्कत है, या तो कभी अटकता है, निगलते हैं तो अटकता है, तो मसल की बीमारी हो सकती है. मसल की बीमारियों में कोई सेंसरी सिम्टम्स होते नहीं है, जैसे कि टिंगलिंग, नमनेस, पेन. मेनली इसमें वीकनेस होता है. तो अगर ये सिम्टम्स दिखते हैं तो मसल की प्रॉब्लम हो सकती है. Thank you. So now that we have acquainted ourselves with the common symptomatology and what should people look out for to know whether there is a neuromuscular disease, let's touch upon a rather intriguing area which actually has been very, very intriguing to me for all these years. Like has been told to you, in the nerve disease, in the muscle disease, in the myasthenia neuromuscular junction disease, there are acquired causes and there are genetic causes. So there is inflammation, there is infection, there is deficiency, which are all acquired, sometimes acquired on top of genetic. And then there are these diseases which are genetic. And I think everyone must be aware of the background of these genetic diseases. So I'll use English language because I think this will be of interest to our foreign faculty also, and they may want to make some comments at the end of it. You know, in many ways, ours is a very interesting country with so many diverse customs and traditions and the systems of marriages, which actually are very intriguing when you study them. If you go back to, this is more for the foreign faculty, the ancient Indian treatises mention that when a marriage is being arranged, there should not be any overlap in 4 generations of 4 genetic stocks: the girl's father and mother and the boy's father and mother. So what they used to see is 4 lineages for 4 generations. So in other words, they were making sure that no genetic admixture occurs. But as we have gone on and as our traditions and customs have been, there are many areas in the country where cousin marriages are practiced. Mama or Banji, cousin marriages are practiced. There are other communities where close relatives marry within themselves. Then there are almost everywhere there are community marriages. So, as I always say, within India, there are small genetic Indias with genetic pools being divided and subdivided. And that is leading to a lot of genetic diseases in the nerve and muscle area, and I'm sure in all other areas of the human body as well. So I think it is extremely important for people to be aware of the fact that our traditions and customs are in some ways in some ways, in social sense, they may be good. In some other ways, they may be good. But medically, some of them are actually propagating the genetic diseases. And I think that is a very, very important area to cover, and maybe we can open it for discussion amongst all the panelists. And if there are any questions from the floor, we could take them. So open for discussion, actually. Shruti, you want to make a comment? Yeah.
Yes, sir. I come from, I fully agree with you. I come from South India, where cousin marriage is very prevalent. And that could be one of the major reasons why SMA is extremely, prevalent in our community in Kerala. So it is quite high in Kerala. And yeah, it's not even that cousin marriages should be avoided. Even the within caste and within community marriages are also reasons. So we tend to do our arranged marriages in that style, and that also propagates.
It's segregating the genetic pools. Absolutely.
Yes.
Absolutely. I think if there is one message from this lay people's talk, it is please understand the genetic implications of the way the marriage customs and prevalent traditions are, so that in future you could reduce them. Maybe we can invite comments about what happens in Japan and what happens in other parts of the world. Dr. Takahashi, you see a lot of genetic muscle diseases?
We see a lot of muscle disease, genetic muscle disease too. But traditionally, marriage, for example, as you mentioned, marriage custom in Japan is also in community based. Just in a small community, people tends to make arrange marriage in a small village. But that causes, the propagation of genetic diseases, especially recessive trait of genetic diseases. So currently, cousin marriages is recommended to be avoided. So because that, I think that the number of the patients with genetic diseases are reduced a lot compared with 100 years ago, maybe. But still, because ethnically Japanese people are relatively similar, so we cannot eradicate the genetic disease. So. Yeah, so we should think about new treatment for genetic disease, including gene therapies.
Yeah. Thank you, Dr. Laszlo. Yeah.
Thank you very much. So I think in my country the marriage is quite, how can I say, free. Maybe a subpopulation in the gypsies that's most close these family traditions, but our nation has acquired mixture of surrounding countries. So I think that therefore it is not a very big problem, this type of how can I manage marriage. But if it is possible, during the presentation, I would have a question to Professor Takahashi, because we heard, and I think it's very important, concerning the statins. Statins used very, very widely in my country and probably everywhere. And I visited Fukuoka several times. And we have a very good scientific collaboration with the Fukuoka University, transgenic mice, so it's an exciting field. But I wanted to ask you that there is a compound which is used in Japan. Its name is pantatin. And pantatin is the terminal region of coenzyme A, and it decreases cholesterol. And I don't think so it's used very widely all around the world. It is not a strong substance as the statins, but statins can be dangerous, especially in high doses, because they influences the CoQ, the ubiquinone. What do you know and what do you think about this pantatin in Japan?
Pantatin. I'm so, Dr. Professor Laszlo, thank you very much for the information. But pantatin, we I have never heard of punteting. So we usually use statin for high cholesterolemia patients. So I think the situation is not so different from Europe. I'm sorry, but I look up about punteting.
Thank you very much. And please, if you find something, please inform me, because I am very much interested in this compound, in this substance, especially because the statins could be so dangerous, especially in high doses. And this is a natural compound, the terminal region of coenzyme A. So it's not a strange compound from the body, and it decreases cholesterol. Thank you very much.
Thank you.
Right. So maybe we'll move on. I think in the interest of time, we should move on a little faster probably. So we'll move on with the message that there are a lot of genetic diseases in India and in Japan and maybe in some other parts of the world. And please understand them so that you can try and prevent them from propagating in the future generations. Now, maybe we can ask Dr. Swati, what are the investigations that are done when nerve and muscle disease are suspected? And then after investigations, we'll go on to the treatments.
So, जैसे कि कोई भी पेशेंट आता है तो इन्वेस्टिगेशन से पहले हिस्ट्री में भी हमको बहुत कुछ इसके बारे में जानने को मिलता है। तो हम जनरली पेशेंट को डिटेल में आपसे हम पूछना चाहते हैं कि आपने क्या करते हैं, आपका ऑक्यूपेशन क्या है, आपकी हैबिट्स में कुछ ऐसा हमें पता चले जिसकी वजह से ऐसा हो सकता है, या आपको और कौन सी बीमारियां हैं, कौन सी दवाइयां आप लेते हैं, ये सब डिटेल में हम पहले जानने की कोशिश करते हैं, जिससे अगर उससे हमें कोई क्लू मिल सकता है कि आपको जो सिम्टम्स हो रहे हैं इनमें से कोई चीज की वजह से हो सकते हैं। दूसरा जो है कि हम फिर उसके बाद एक डिटेल में हर डॉक्टर आपका एग्जामिनेशन करता है, उससे भी हमको ये जानने को पता चलता है कि जो आपकी तकलीफ है और वो सच में नस या मसल की प्रॉब्लम की वजह से ही हो रही है या इसका कोई और दूसरा कारण भी हो सकता है। उसमें जो है हम आपको वीकनेस है कि नहीं, आप जो सेंसेशन की आपको जो प्रॉब्लम है वो आपको कितना तकलीफ है, किस जगह पे है, उनसे हमें जानने को पता चलता है कि आपको ये नसों की तकलीफ है या मसल की प्रॉब्लम है या आपके स्पाइन में से प्रॉब्लम आ रही है या ब्रेन में से आ रही है। उसके अनुसार आपके डॉक्टर जो हैं फिर वो डिसाइड करते हैं कि सबसे पहले कुछ ब्लड टेस्ट भी करा के देख सकते हैं कि इसमें कोई चीज की, जैसे हमने बोला कि कभी-कभी ये विटामिन की खामी की वजह से हो सकता है या कोई थायराइड के डायबिटीज की प्रॉब्लम के हिसाब से हो सकता है। तो उसके अनुसार पहले थोड़े ब्लड टेस्ट करके भी देखते हैं हम लोग कि उसका कोई कारण हमें ब्लड में दिखाई दे रहा है। कभी-कभी ऑटो इम्यून बीमारियां होती हैं तो उसके लिए भी कई मार्कर्स हम ब्लड में चेक कर सकते हैं। कभी-कभी जो है कमर में से पानी निकाल के भी हम रिपोर्ट करते हैं, स्पेशली जब हम नसों की तकलीफ सस्पेक्ट कर रहे होते हैं, क्योंकि कई बार पानी में कोई इन्फेक्शन हो, जैसे टीबी हो, उसकी वजह से नसों में तकलीफ हो, आपको झंझनाहट होती हो, ऐसा भी हो सकता है। या फिर ऑटोइम्यून बीमारियों में हमें पानी में एक पैटर्न दिखाई देता है जिसके लिए हम कमर में से पानी निकाल के उसकी तपास करके देखना चाहते हैं। इसके अलावा जो है आप स्पेसिफिकली जो नस और या मसल की बीमारी है उसके लिए हम इलेक्ट्रिकल टेस्टिंग करते हैं, जिससे हमें पता चलता है कि कितनी नसों में तकलीफ है, आपके नर्व्स किस तरह की प्रॉब्लम है, उसमें किस टाइप की नर्व में प्रॉब्लम है और कितनी प्रॉब्लम है। तो उसके लिए जो है एक उसमें जो डॉक्टर हैं थोड़ा थोड़ा करंट देते हैं नसों को और फिर नसों की रिपोर्ट करते हैं, और उसके आगे जो है मसल्स में नीडल डाल के भी, एक सुई डाल के भी आगे तपास की जाती है। उससे भी अपने को पता चलता है कि मसल में इन्फ्लेमेशन है कि नहीं, मसल में वीकनेस है कि नहीं। जैसे आपने पहले सुना कि मायोसिटिया ग्रेविस जो है न्यूरोमस्कुलर जंक्शन का प्रॉब्लम है, उसकी रिपोर्ट टेस्टिंग भी इस इलेक्ट्रोफिजियोलॉजी के थ्रू किया जा सकता है, जिससे ये अपने को पता चले कि वो जंक्शन में कोई प्रॉब्लम है, तो वो टेस्टिंग भी की जाती है। कभी कभी हम लोग मसल या नर्व की एमआरआई करने को भी पेशेंट्स को बोलते हैं, क्योंकि आजकल इन सब नई जो टेक्नोलॉजी है एमआरआई, उसमें जो कौन से मसल्स इन्वॉल्व हैं, उनके पैटर्न से भी हमको पता चलता है कि किस तरह का मसल में रोग हो सकता है। और अगर अपने को कभी ये तो उसकी मसल की बायोप्सी करने की जरूरत पड़े तो कौन सी मसल में से बायोप्सी करना ज्यादा अच्छा रहेगा पेशेंट के लिए, वो भी इंफॉर्मेशन हमें एमआरआई के थ्रू पता चलती है, जो ईएमजी से भी पता चलती है पर एमआरआई से भी वो इंफॉर्मेशन हमको। तो सब चीजों को हम एक साथ करके करें तो हम पेशेंट को ज्यादा अच्छे से हेल्प कर सकते हैं। और कभी कभी रेयर केसेस में हम लोगों को बायोप्सी भी करना पड़ता है। अगर इन सब टेस्ट से हमें पूरा कंक्लूजन नहीं मिल रहा है या हमें और कुछ ज्यादा जानने को चाहिए, तो कभी कभी हम नर्व की या मसल की बायोप्सी आगे भी करते हैं। और जैसे हमने सुना कि जेनेटिक टेस्ट, तो जेनेटिक कारणों से भी ये रोग हो सकते हैं, तो उन केसेस में जेनेटिक टेस्टिंग भी आगे किया जा सकता है, जिससे किस जीन में खराबी है, कौन सा पैटर्न ऑफ इनहेरिटेंस है, कि ये डोमिनेंट है कि रिसेसिव है, किस टाइप का जेनेटिक डिसऑर्डर है, वो सब जानने के लिए जेनेटिक टेस्टिंग भी आगे की जा सकती है।
Right. Thank you. Thank you. Maybe we could just mention for everyone's benefit that almost all the genetic tests that can be done are available in our country now, in the private sector as well as the research sector and the government sector. So I think whenever a genetic disease is suspected, the facilities are there, even though some of them are expensive in the private sector. In the government or research sector, it may take time before the results can come, but the facilities are available. So maybe an open question to everyone: do you think the number of biopsies that we need is reducing a lot after the genetic tests have come?
I think so, for sure.
Does everyone think so? I think the number of biopsies is only being kept for situations that are not clarified by the genetic testing. So it's like you said, it's history, clinical examination, and then if genetic, then you move on quickly to that side. And is that the same situation everywhere in Japan or Europe or Spain? Biopsy number is dropping strongly and the genetic tests are being more easily done. I think that's what's happening everywhere. No, in Europe is the same situation, or Japan?
In
Spain?
Japan, I think for muscle diseases, the situations are a little bit different. If without muscle biopsy or the muscle pathology finding, we cannot classify the disease. So we usually do a genetic test combined with a muscle biopsy, because the information obtained from the muscle biopsy is enormous. And after that, we can go on to genetic tests.
Right. Any other comments on this?
Dr. Nair wants to make a comment, I believe.
Yes, Shruti.
So thank you. This is a wonderful question, because I find that the role of muscle biopsy is changing. So earlier we used to do it for dystrophinopathies and dysphalinopathies and everything, so which we could identify by IHC. Now we are trying to find out the complex cases and where the report there are more than one muscle diseases. So we have patients where you have both myofibrillar myopathies and GNE, both genes VUS comes. Then you have to find out which one is problematic. And of course, where genetics come negative or when we suspect acquired causes. So their role is changing, I believe.
Absolutely. And also I think in research setting, like when you want to know how the mRNA is behaving, what's actually happening at the muscle level. So from diagnosis, it is probably shifting a little to complex diagnosis and to more understanding of the muscle diseases. So let's move on to what
Shefali wants to make a comment.
Yes, Dr. Gulati, yeah.
I was just saying that I agree with both of you completely. I just wanted to add that for last couple of years, we've been trying to work on whether skin biopsy can be used as a replacement for muscle biopsy in some situations, which becomes important when we are doing in research the trials and we're going to see and follow up a patient, because skin biopsy, because of the rectal pylori muscle there, and it's non-invasive, it'll be easier for parents to give consent for repeated skin biopsy. So that was the other thing.
Yeah. That's a very, very good point. Yeah. And there's a lot of work from AIMS on that already. Yeah. So shall we move on to the next bit, the bit that everyone wants to hear, the treatments. And in many ways, I think this is a better era than the years that have gone by, that things have started appearing on the horizon. Some have appeared on the horizon. Some are out of reach financially, but are there. So treatments are coming up in various ways. So maybe, Dr. Gulati, you want to tell us about treatments for SMA and DMD in children, because those are the two that are really leading.
So at the outset, I want to tell everybody is chasing the definitive cure, but India, there is a big problem. The holistic, multidisciplinary, supportive care is getting neglected, which has to be done. That has to be kept in mind before we proceed. And whatever the standard therapies are, like you have steroids in DMD, have to be given, because the other definitive therapies which are coming, wo uska add-on hai. And other thing is, we forget about transitional care, क्योंकि ये बच्चे होके ये adult में जाते हैं, so we have to have the transitional care. And fourth thing which I feel we neglect is palliative care. जो SMA type 1 वाले हैं, जो काफी sick होते हैं, which में the responses नहीं आ सकता है for the definitive therapies, we have to give a life with dignity and work on palliative care. Definitive treatment जो available है, very briefly, SMA के अंदर हमारे पास 3 treatment options available हैं. एक उसका जीन थेरेपी है जो जोल्जेस्मा है, जिसको इंट्रावेनस इन्फ्यूजन देते हैं. उसका अप्रूवल अभी वर्ल्ड ओवर इज FDA अप्रूवल इज फॉर लेस देन 2 years, एंड वो एक इंजेक्शन 16 करोड़ का है. तो वो हमारे लिए, सब लोगों के लिए पहुंच के बाहर है. इट इज अ प्रोहिबिटिव कॉस्ट, बट उसका डेफिनेटिव इम्प्रूव है. लेकिन जो है द अर्लियर वी डू, उसमें बेटर रिस्पॉन्स है. अभी ट्रायल शुरू होने वाले हैं, जिसमें वो 2 to 18 years पे ट्रायल कर रहे हैं इंडिया में 3 साइट में, एंड एम्स इज वन ऑफ द साइट. सेकंड ड्रग इज न्यूसिनर्सिन, जो सबसे पहले आया था. वो रीढ़ की हड्डी में देते हैं, उसको रीढ़ की हड्डी में देते हैं. शुरू में 4 इंजेक्शंस बोलस में देते हैं, उसके बाद 4-4 महीने में पूरी लाइफ में देते हैं. तो उसके अंदर भी रिस्पॉन्स है. एक इंजेक्शन $75,000 का है, लेकिन जो फर्स्ट ईयर का कॉस्ट होता है 4.1 करोड़ होता है एक छोटे बच्चे के लिए, और बाद में 2.1 करोड़ पर ईयर है. तीसरी दवाई जो है वो ओरल है, रिस्टीप्लैम, जो अभी लेटेस्ट अप्रूव हुई थी 2020 में, अगस्त में FDA अप्रूव हुई थी, और इंडिया में जुलाई 2021 में आई है. और वो ओरल ड्रग है, रोज लेनी होती है. और उसका भी जो कॉस्ट पड़ता है वो 2.5 करोड़ पड़ता है विदेश का, लेकिन वो जो कंपनी दे रही है वो पेरेंट्स को कुछ कम करके हाफ 1.5 के करीब पड़ता है पर ईयर. तो कॉस्ट आर वेरी एक्सपेंसिव, बट आई वांट टू टेल वन थिंग कि मैजिकल नहीं है, बिकॉज हमारे 10 पेशेंट्स को मिल चुका है जोल्जेस्मा, और हमारे 13 + 38 पेशेंट्स को न्यूसिनर्सिन मिल चुका है, और अभी 9 को रोश का ये रिस्टीप्लैम. रिस्पॉन्स है, इंप्रूवमेंट है, मोटर माइलस्टोन्स में इंप्रूवमेंट है, पर ये नहीं है कि ये ट्रीटमेंट से वो बिल्कुल चमत्कारी रूप से बिल्कुल भागने दौड़ने लगेगा. गेन ऑफ माइलस्टोन्स है. एंड DMD में जो ट्रीटमेंट है अवेलेबल, वो अभी मेन स्टे अभी भी स्टेरॉइड थेरेपी तो है ही है. जो न्यू ट्रीटमेंट आए हैं वो आए हैं बेसिकली जो अवेलेबल है. रिसर्च तो बहुत
We can't hear you, Dr. Gulati. Chandrasekhar, can you hear?
No, I think we have lost connection with her.
Okay, so we'll come back. We'll come back when she comes. So maybe for the foreign faculty, what was discussed is that the SMA and DMD drugs are available, but they are very expensive, and some strategies need to be designed to try and bring them in the within the reach of people. Is the situation very different in your countries? Are the drugs still prohibitively expensive? Dr. Laszlo, or Dr. Takashi, or Dr. David, can your patients take the drugs through agencies, or it's still difficult? In India, it is still quite difficult.
In my country, so we had big difficulties. I don't know, can you hear me?
Yes, we can. Yes.
We had big difficulties in the treatment of SMA, but now the situation is much better. Of course, it's a terribly expensive drug, but finally the government decided to support this drug. So now the situation is better. Another question, unfortunately, I had some problems with my computer to hear the presentation. I don't know what is the situation with eculizumab in India, because we are just working on this drug to use in myasthenia, and there is a big, how can I say, a big professional fighting to get it. That's also very expensive, not as expensive as the genetic therapy, but expensive.
I mean, eculizumab is not very much available and within the reach of people in India, but rituximab is having a field day. Rituximab is being used more and more by more and more people earlier and earlier. So I think the day belongs to rituximab in India at the moment, I think. Yeah.
Thank you very much.
Yeah. I think maybe one other drug.
Sir, I'm sir.
Yeah.
I'm sorry. I lost the connection. I'm
Yeah,
very
yeah.
sorry. Yeah, I'll just
yeah. Yeah. Please. Yeah.
Sir, was I audible till giving the steroid as a mainstay? Mainstay बोल दिया था. उसके बाद I was talking about the antisense.
No, I think steroids. Steroids also we couldn't hear. So maybe you tell them because very important.
Okay. DMD के अंदर जो है बेसिकली अभी स्टेरॉइड्स में स्टे है केयर का, उससे मसल की जो वीकनेस बढ़ती है उसको कम किया जाता है. तो इट इज नॉट कि वो ऐसे ही दिया जा रहा है, तो वो देते रहना है. उसके अलावा जो न्यू ट्रीटमेंट है वी आर अवेलेबल जो है वो एक्सॉन 45, 51 और 53 है, लेकिन वो ये 3 डिजिट्स नहीं है. दे आर 1948 एंड मतलब काफी मतलब 60-70 करीब के है, बिकॉज जो डीएमडी की जीन होती है वो बहुत बड़ी है. 7000 से ज्यादा म्यूटेशंस हैं इसमें, करीबन अराउंड 100 के करीब म्यूटेशंस को कवर किया जाता है. तो सारे पेशेंट्स ऑफ डीएमडी के लिए ये नहीं है. कुछ स्पेसिफिक एरियाज में जहां डिलीशन होती है वहां पे ये दवाई जाके चिपक जाती है एंड वो जो डिलीशन का एरिया बाईपास हो जाता है. लेकिन वो भी रामबाण नहीं है, इंप्रूवमेंट है. उतनी इंप्रूवमेंट नहीं दिखाई गई क्लिनिकली जितने एसएमए में है, एंड वो भी कॉस्ट बहुत एक्सपेंसिव है. फॉर अ 20 kg चाइल्ड इनका जो रेंज एनुअल है 6 to 8 crore अ ईयर है. गवर्नमेंट ने रेयर डिजीज पॉलिसी के अंदर सपोर्ट दिया है, पर उसमें मैक्सिमम सीलिंग एज ऑफ टुडे इज 50 lakhs पर पेशेंट. सो अभी वो उसके ऊपर चल रहा है. सो इट इज कॉम्प्लिकेटेड इन दैट वे. बाकी सब तो ऑल आर मोर ऑन इन रिसर्च. सॉरी अबाउट द टेक्निकल कनेक्शन सर.
No. These were very important points. Maybe just to carry that a little further, within for Indian people, steroid is a frightening word. You know, even though steroids have their benefits, the side effects are portrayed very much, and everybody is afraid. When you say that you want to start steroids, they get very worried. So, Dr. Pal or Dr. Swati, do you want to tell people about what should they be on the lookout for when the steroids are used? Are they really such terrible drugs, or?
No, that is not a terrible drug. And the best thing for steroid in DMD is patient is going downhill. At that point of time, it is easier to convince the parents to start a drug which can somehow stabilize or for time being can improve slightly. So this is not that much problem to convince the family members.
So what sort of monitoring would you advise people who are put on steroids?
First thing is weight, body weight, blood sugar, definitely even blood pressure, even though they are children, and the activity of IADL. I need to address whether the patient is improving or I am just going and the patient is deteriorating. So we need to check the clinical profile along with the complications.
Right. Diet, probably one of the important things.
Yes.
No, Dr. Swati, you want to make any comments about what should they do about the diet when steroids are started? Because that's something that comes up in discussions almost all the time.
So in general, with the kids, it's a little bit more hard. So for adults, it's much easier to tell them, don't eat this and that. For kids, especially with the junk food and all the fried chips and pizzas and the cheese and all that thing coming up in our market, and everybody, all the kids are getting more exposed to these things. Weight management is becoming a little bit more harder in kids than in the adults. And so I have to tell the parents to try and restrict them. So you can tell them you can have it once a week, and the other days you can have the other things, and you would have your cheat day and you can have those things on one day a week, kind of, so that the kid doesn't feel that he's kind of deprived of these things. And I also tell them to encourage intake of milk, and especially with the bone health also, and also monitor their growth, because sometimes because of the steroids, their growth might also be impacted. if you start them on early. So those are the things, especially with the kids, we watch for. But adults, definitely more for the diabetes and the blood pressure, risk of infections and everything that we have to manage with steroid.
Yeah, thank you. I think we are at 8 o'clock, stipulated end time. So let me just sum up what we have done and maybe make one or two comments and then pass it on to Dr. Meshram. I think we basically saw in today's session which are the common diseases of the nerve, neuromuscular junction, and muscles. Then we saw how they present, so which symptoms they come up with, which is very important for people to be on the lookout for. Then we saw some of the investigations that are done, and then we went to various treatments, and we also requested our foreign experts to talk about what's in their country, and with some differences, I think everyone is facing similar problems. So about 10% of neurological diseases are neuromuscular diseases. It is important for people to be aware as to how they present and quickly reach their doctor, because quite a few of them are treatable. It is very important for people also to understand that a sizable proportion of these diseases is genetic, and therefore they should try and evaluate whether these diseases can be stopped from progression in their own families or in their community. Investigations are largely available in India, and they can take advantage of that. And lastly, this area that looked rather bleak a few years ago, now there is a lot of treatment options that are coming up. Some diseases have already started improving, and we are talking of cure in some other diseases, immunological diseases, and some genetic diseases. So the coming time is much better and will be much better than the years that have gone by in neuromuscular disease. To sort of support all this that we did, a couple of things that I would like to say is that the public participation in these comparatively uncommon diseases is very, very important. See, if the government of India asks a question, how many Duchenne dystrophy patients are there in India? We don't know for sure. We do not have a registry. How many spinal muscular atrophy patients are there in India? We do not have a registry. So I think it is very important at the level of lay people to participate with their healthcare providers to formulate good nationwide registries, to really understand the magnitude of the problem, and then as a patient group to be able to participate in advocacy for these very expensive drugs. I mean, these drugs are so expensive. Unless there is a perspective to it given by patients, parents, and healthcare providers, what we want to achieve will become more difficult. So I think those are some of the challenges facing people working in nerve and muscle disease in India. And we do request all of you to participate more and more in the healthcare. It's not only the medical people who need to fight the battle, it's your battle. We will try and help you. So I think with this, I don't think there is anything else to say at this point in time. Maybe we'll open it for a minute or two for everybody for a parting message, and then I'll hand it over to Dr. Meshram. So please go ahead. There is a comment from Partha Ray, promote research in neuromuscular disease. Very true. Thanks, Partha.
Yeah, comments from yes, Shruti Nair.
Thank you, sir. You have very beautifully summed it up. My only additional point I would say is at this point we should try to find answers to all the genetic questions that are left behind. So there are many patients we have not ever evaluated because of lack of resources. Now we have the genetic resources, as I have very clearly mentioned earlier. And genetic counseling should also be very thoroughly done for genetic diseases now that we have avenues to treat them. Thank you.
Sir Vexi Laszlo.
I think it was a very variable discussion. And what we heard the last time, the registries and the follow-up of the patients are very important, I think, all around the world, not just India, but everywhere, because that is our responsibility to have these correct registries and to communicate with the decision makers concerning the treatment. Thank you very much.
Thank you. Professor Yusuke Takahashi.
I really enjoyed and learned a lot from this discussion. And I also echo the comments of Professor Lexi Lazaro, because registry is very important to promote the research of neuromuscular diseases. In Japan, we established a big registry of Duchenne muscular dystrophy. It works very well for development of new drugs. So I really hope that such a registry is also established in India too. Thank you very much.
David?
Thanks again. I learned a lot from our Indian colleagues and international colleagues, and I totally support the need of further research, because this is the only path to improve our patients' lives and prognosis. And this is something very important. We should do the best possible effort in harmonizing the research internationally. And this thing that came with the COVID, which is the Zoom and all these platforms, maybe the tool to be used in the collaboration within countries to promote a more homogeneous research. Thank you very much.
Thank you. Thank you. Shefali?
Sir, I wanted to say that we have a registry. ICMR has started a registry of rare diseases, out of which for neuromuscle, we have only 3 as of now: SMA, DMD, and LGMD. We are also at the Center of Excellence in Advanced Research developing a consolidated registry for neurodevelopment and neurological disorders. Secondly, regarding research, there is a group, a consortium which has been developed in ICMR. I am co-chair of that, in which discussing about the research options for neuromuscular disorders. And then also there were meetings with the pharma, there were meetings with the parent association separately, so as to understand how to get everybody on board. And thirdly and last, actually it was just mentioned, and I wanted to, Shruti mentioned, but I wanted to reiterate that we have many parents, many families with 2 and multiply affective SIMs, which is a failure of our doctor fraternity. I think we should understand, and it is very important for genetic counseling and prenatal diagnosis. SMA, DMD happening again and again. I think we are all failing in our job. Thank you, sir.
Thank you. Any other comments by any panelists? Okay, I think we had a wonderful discussion, and I would like to thank Professor Satish. You want to say something? Professor Laszlo Vexey, Professor Yusuke Takahashi, and Professor David Garcia Azarin for staying for the whole session. In fact, I had said them that you stay. You can be in the beginning, make the comments, and if you are short of time, you can log out. But they participated in the whole session. Thank you very much for being with us. I would also like to thank Professor Wolfgang Griswold. He joined and making useful comments, and Satish Kadilkar for wonderfully conducting the panel discussion. And as always, and the panelists Stuti, Shefali, Swati, and Sandeep. And would like to thank Professor Nirmal Surya for giving this opportunity, and would like to say something, Dr. Nirmal?
I will only tell मेरा इतना ही बोलना है कि जो लोगों ने आज ज्वाइन किया है, उन लोगों ने ये समझना चाहिए कि ये जो बीमारी है, कुछ सालों के पहले हमको ऐसा लगता था कि लाइलाज है और कुछ नहीं कर पाएंगे। उनके बारे में इंडिया में भी काफी काम हो रहा है, जैसे डॉक्टर शेफाली ने बताया, और बाहर भी काफी रिसर्च हो रही है। जरूर कॉस्ट बहुत महंगी है इनकी ट्रीटमेंट की, लेकिन एक होप आपको मिली है कि इन बीमारियों का इलाज हो सकता है, और फ्यूचर के लिए एक बड़ा होप है कि आपको कई सारी ऐसी जो बीमारी है जिनका अभी तक कोई इलाज नहीं था, उनका इलाज जरूर मिलेगा। तो आप लोग यहाँ पर जुड़ते रहिए ताकि ये जो अपडेट आप लोगों को मिल रहा है वो मिलता रहेगा, और कई जगह पे आपको जो फॉरेन के एक्सपर्ट हैं उनका एक्सपीरियंस और हमारे इंडिया में जो काम हो रहा है, कई लोगों को नहीं मालूम होगा कि एम्स में क्या काम हो रहा है या दूसरे इंस्टीट्यूशन में क्या रिसर्च हो रही है, तो खाडिलकर साहब क्या रिसर्च कर रहे हैं या और भी कई साइंटिस्ट जो हमारे IAN के मेंबर है वो क्या रिसर्च कर रहे हैं, तो उनके बारे में आपको जानकारी मिलेगी और आपको एक सही निर्देश और दिशा की जानकारी होगी और आप लोगों को उसका फायदा होगा। तो आप लोग जुड़े रहिए और डॉक्टर मेश्राम जो है आगे के कार्यक्रम के बारे में आपको बताएंगे जो कल होने वाला है।
थैंक यू वेरी मच डॉक्टर निर्मल सूर्या। दूसरी and one important thing that I want to mention is that don't wait for the symptoms to occur. That people think that I don't have diabetes. You should check, then only you rule out the diabetes, because sometimes the neuropathy can be the first presentation of diabetes. Sometimes you take medicines and you feel that they don't have any side effects, like Ayurvedic medicine. I have seen many patients taking Ayurvedic medicine which contain heavy metals and presenting with neuropathy. So you must tell your doctor that what medicine you are taking, even if you feel that they don't have side effects. So same is true with the statins. And the most important aspect is control of diabetes and the obesity is not by the drugs, but it can be very easily controlled by the diet. We'll talk about that sometimes. Tomorrow we will have a very interesting session on backache, neck pain, very common problems: spondylosis, cervical spondylosis, lumbar spondylosis, bladder problems, bowel problem, and sexual dysfunction. Dr. Abhishek Srivastav is the moderator, and we have very interesting faculty. Dr. Hagen from UK will join. She is an expert in these bladder bowel problems. And we have as a panelist, Professor Manmohan Mendiratta, Dr. Suresh Shankla, who is a neurosurgeon. And then we have two more panelists from India. So we are going to have a very interesting session tomorrow. And please join for this session. Thank you very much. And once again, I would like to thank everyone for participating in this session. Thanks.
Chandrasekhar would like to thank you and Nirmal for arranging such a beautiful program. Many compliments.
Thank you, Satish. Thank you, Professor Laszlo. Thank you very much. Thank you, Yusuke. And thank you, David.
Thank you.
I think because of this,
bye-bye.
we can
Bye-bye.
together.
Thank you.
Bye-bye.
Thank you, sir.
Bye. Thank you.
Thanks.
Thank you.
very much.
Thank you.
Thanks.
Thank you, everyone.
Bye.
Thank you.
Bye. Thanks for
Bye.
the opportunity.